now move on to our next session. And I would like to welcome everyone again to this session of the Gratitude Week. This is an initiative of the Health and Wellbeing Council to bring everybody together to say a heartfelt thank you to our doctors, nurses, and our entire healthcare ecosystem celebrating National Doctors Day on July 1. And this Thanksgiving marathon is our endeavor to thank all our healthcare heroes for a whole week, and we carry this gratitude in our hearts forever. Our healthcare heroes have toiled hard for over a year to save us from the COVID-19 pandemic, putting in endless hours and sleepless nights to ensure that patients are cared for and recover from their illnesses. While doctors on the front line of the COVID battle were completely stretched, operating in hospitals overwhelmed during the recent second wave of the pandemic, their peers were also hard at work, relentlessly caring for those patients with chronic diseases like cancer. Now, cancer patients are immunocompromised and need special care to ensure that they do not contract the COVID-19. As patients of a chronic disease, their treatment is long-term, which, if delayed or deferred, can have a significant impact on their well-being and their disease progression. How have cancer hospitals managed to protect their patients from COVID while continuing with their treatment? What extra precautions need to be taken? These are some of the issues that we will discuss in this session. This session is supported by Roche, and we are grateful to them for bringing up the issue of cancer care during a pandemic. Please welcome our esteemed guests who are joining us for this session. We have Ms. Ambili Vijayaraghavan, the Chief Operating Officer, Aster, Medcity, Kochi. And we have Mr. Sathyanarayana Golgar, AGM Supply Chain Management, Karnataka and Maharashtra region, Aster Hospitals, joining us in this session. Thank you both for joining us for this session. Such a pleasure to have you with us. Ms. Ambili, let me start with you. What has been the impact of COVID on specialty cancer care hospitals like yours?
So I would say that, from the generic point of view, most specialties have suffered in terms of, what happened when the lockdown happened and when we first figured out that we were dealing with this kind of pandemic. But cancer patients in specific had a couple of, very, very unique problems. One being, traditionally in all our hospitals, patients normally come with a whole lot of relatives and bystanders with them. And it was during this time that we realized that kind of support, it's a lot of emotional support to the patient. We were not able to cater to this particular requirement as far as cancer patients specifically, or others as well. But I think the impact on these patients who were immunocompromised, who had this difficult disease to deal with, was quite visible. And so we had to figure out ways and means and how to accommodate these kind of requests. Also, one of the things that we realized was that as far as patients are concerned, a lot of small businesses and the income in general for patients actually was quite affected. So we had quite a few requests where patients were not able to pay for treatment, especially the high-end immunotherapy. And we had to make out different unique models to help support them during this difficult time as far as the cost of treatment goes. Also, Aster Medcity specifically deals with a lot of overseas patients. People come here for chemotherapy cycles only from abroad. And, because of the fact that airlines were not functioning, we had a whole lot of treatment that were delayed during this process. So overall, it was about accessibility. It was about cost of care. And while in the hospital, the kind of accessibility they had to various places that got affected.
Okay, so a lot of issues that you brought up. Mr. Golgar, want to understand from you, ma'am has highlighted the patient aspect, the fact that flights were not coming in, those are operational issues, but even crowding of patients, the care that they needed, the cost. She's highlighted a lot of the patient-related issues for us. For a specialty cancer hospital like yours, did you face any logistical outages, drugs that were short supply, or specific devices that were required and were not available? Any of those issues did you face?
Yeah, good afternoon to everyone. See, as you rightly said, during the phase one of COVID, people were hesitant to come to the hospital, but it was vice versa in the case of phase two. People were rushing to the hospital in wave two, whereas in wave one, people were hesitant to come to the hospital unless it was so, desperate and emergency. During this period, what happened? We have felt in Bangalore market. Always Bangalore is crowded, as you all know. It is traffic jammed, and people were struggling to reach the hospital on time and kind of thing. But we have seen that complete lockdown was announced, and the public transport was not really possible for them, and they should spend extra money from their pockets. And when they come to the hospital, extra PPE kits are being charged. Then antigen tests were supposed to be done to identify whether they are COVID patients or infected patients or non-infected patients. Then treatment planning, before the chemotherapy procedures and other things, they have to undergo some tests. All these are, plan was really, going haywire. Nothing could be planned in terms of perfection, when we say. And additional cost was being, experienced by the patients unless they're covered by corporate schemes or insurance. This was a pain point that the patients have experienced. And on top of that, the chemotherapy cycles have been extended to maybe 21 days from 15 days of cycle time. So these were all, some of the patient experience that we had. Apart from that, we had good number of nurses being infected with COVID. So to cover the manpower requirement of the hospital, this was a challenge. Then, to segregate these patients from COVID and non-COVID, this was requiring a lot of, hospital space to accommodate. And, in case if the patients who are suffering from cancer, if they are COVID positive, then they must have been kept in a separate room, kind of, special room, or maybe a single room kind of thing. So we can't generalize their treatment along with other patients who are in the hospital. These were some of the challenges. Then again, after the work hours of our healthcare workers, so how do we segregate them? Should we keep them in the same nursing hostels, or should we have a separate hostel facility for those who have been COVID affected? These were some of the challenges that in the wave one, which we could able to understand and quickly manage our infrastructure, or maybe the facilitation part of it. And coming to the economic crisis that we have faced in the hospital is that, the credit business has, increased, whereas the collections were decreased. Then the point of, the cash patients whom we are treating at the hospitals has decreased. So cash in place, then, the demand for materials and, drugs was more during this thing, and which were really, affecting our, cash flow. Then vendor payment issues, all this, we have experienced over the, first wave kind of thing. However, we could able to manage the wave two, in a little proper way, though there was a, fully occupied beds in the hospital with the government reception of maybe 75% reservation for government patients whom they have referred from, the government authorities. So we could able to manage wave one and wave two, if you ask me, in a very professional way and to the satisfaction of the patients. And we could able to retain all these patients whom, we were treating earlier, and they are our loyal customers even today.
Ambili, I want to understand from you, the patient aspect. Now, wave one was done when we did not know much about this virus. We know better now. So, guidelines have come in on how to treat chronic patients, etc. Was your hospital taking care of COVID positive cancer patients? Did you have a system to triage the patients? What were the SOPs that you were following?
Right. Yes, we treated, at one point in time, our hospital had over 150 COVID patients, COVID positive patients. Of course, they were not limited just to cancer because we are also a large multi-specialty hospital. But the entire system of the SOPs were actually built around how we screened, like you said, triaged at the point of entry. And we what we did was, we had to make some infrastructure changes at the level of entry. So this was pretty much done as an extension of the emergency area, where we actually built an entire triage bay to triage such patients, and it didn't matter which specialty. But cancer patients in specific, because they had to be protected, right, had to go through sort of a lot more focused and a lot more sterile kind of channel. So this specific area actually had different team of staff who took care of the entire triage process. So the SOPs were built around planning for the arrival of these patients, once they come in, the time that they spent in the triage area, how would investigations be done for these patients. There was a time frame given for investigation so that they don't mix too much with the other patients. And then what then happened was that we divided the entire hospital based on the AHU zones to actually segregate patients who are known cases of COVID vis-a-vis the others. We had physical segregation as per government guidelines between these areas. And there was a system of screening and a system of like sort of a tick kind of a checklist kind of a system at the screening level, at the triage level. And then, of course, in the patients then went off to the area where they would get subsequent treatment. So most amount of precautions in terms of HVAC, in terms of infection control, were actually for these areas where our most vulnerable patients were kept.
Okay, but you were taking care of COVID positive patients as well, right?
Yes.
So I'll come back to you, Ambili. What were the facilities? Did you have special wings for them, special towers for them? How did you ensure that, care is separate? Was the staff also separate for COVID versus non-COVID cancer patients?
So it was like a hospital within a hospital. Everything that was required to care was replicated specifically for COVID positive patients. There was absolutely no mixing of staff or any other infrastructure. So we're actually duplicating everything because the kind of transition between these two areas had to be kept to a minimum. We paid a lot of attention to the HVAC because air mixing should not have happened, and that is one area where we actually ensured that the AHUs were kept separately so that there was no air mixing. In terms of things like consumables, medicines, etc., we had to make sure that sufficient stock was available in these segregated areas. Again, to prevent cross-infection, to prevent movement of staff between these two areas. One of the other big challenges was about non-symptomatic relatives who could possibly carriers, and how they had to be screened and segregated so that they do not become then reasons of our in-house patients being exposed to the virus. So we put in a lot of strict, stringent measures on screening of relatives and anybody who's not supposed to be in that area, so that very, very minimum traffic happens at the area. So what we've noticed over the last 1.5 years is that any high traffic area is a potential area where the virus easily spread. So in all of these areas, we actually kept screening mechanism and access control so that unnecessary traffic into these areas was avoided.
Okay, we avoided the traffic. Mr. Golgar, how did you physically and administratively, prepare for what Ambili is described? Like, you had separate sections, staff was separate, HVAC was different. It's like a hospital within a hospital. When did you start planning for this? When did you start implementing these changes?
Yeah, early May last year, we have started these ideas of separating the hospital inside the hospital by barricading some of the areas where we can barricade and separate out the creation of extra exits and entry points for COVID and non-COVID. And we had the core team formed for deciding, immediately on certain issues like, for example, like nurse gets infected with COVID. And, how do we take it forward? What is the options available? How do we ensure that the patients are not getting infected? When the doctors are on duty, how do we manage their stay and accommodation at the, nearest to the hospital so that they did not go to their home and, infect all their family members. Some of the key members in the treatment plan were being, discussed about their arrangements in the line of treatment and kind of thing. And infection control team was very much there for deciding all these parameters, and the administrative team was very much there to decide instantly on certain arrangements, even if it is costing some extra little money. So all these decisions were taken on an instantaneous basis, right? So that helped us, to plan, and all our senior leadership members were coming to the hospital on a daily basis to monitor this activity. So there was a lockdown, which was prevalent in Bangalore, and we were trying to create some kind of motivation to the people who are really fighting the COVID-19, so that they don't get demotivated, because all senior leadership team will be at home and these people will be fighting with the COVID patients, and they don't know what to do. This kind of situation could have created, but we have made it very clear for everybody that we are into the healthcare services and we expose ourselves to the patient's infections and other things, but we take precautions. When we go to home, we just remove our clothes off and take a bath and sanitize ourselves, and have social distance in the family for overcoming all these things. And it was a continuous training that we have given to all people that they were under this care of patients. So this is how we have managed in our hospitals.
This has involved a lot of personal sacrifice also, and quite rightly, you're amongst the COVID frontline warriors who have helped us overcome these tough times. Now, Ambili, did you really face challenges once you got everything set up? How long did this take? In the interim, were there any challenges?
I'm sorry, your voice broke. Could you repeat?
I want to understand, once you had this system set up, what were the challenges that you faced?
Okay, so whereas we did everything to plan, and we had this loads and loads of meetings on possible scenarios and all that, the truth is only when patients started coming in, a lot of it was also about reacting properly and ensuring we did a lot of course correction. Now, a couple of the things in terms of course correction was, at some point in time, our own staff got infected, right? So we had to then quickly look at what are the alternatives. I mean, you have staff that's working for long hours with that PPE, which is an extremely difficult, taxing task. So idea was to, okay, what do you do in order to keep those people who are on the floor intact and safe and motivated? So a lot of us, in fact, thought about things like leadership rounds, walking the talk, because I think, like my colleague mentioned, it's one thing to say, provide everything and expect them to do it. But the other bit is to go be on the ground and ensure that they know that you're behind them. So I think my biggest challenge, even after such meticulous planning, was that when these unexpected things happened on the floor, how quickly did we take decisions, make course corrections, and ensure that we gave that confidence to the team on the floor that we're there behind them. Even things for infrastructure related things, let's say somebody for that particular patient, there was something specific required. How quickly, remember these were days of lockdown, how quickly were we able to mobilize all these resources and get it for them on the floor? So it was these little things that mattered. And in terms of infrastructure, in terms of resource availability, especially manpower, I would clearly say our biggest challenge was manpower, and how we dealt with alternative models of manpower and what we did for them, while they were in the hostels or people who got affected. That actually was our biggest, in terms of problem solving. I think that's the most amount of time was spent on that.
Okay, could you elaborate a little on your manpower challenges and how did you overcome? Because you said that it's understandable that the staff would also, perhaps they were at risk. Some of them would have acquired the infection. Also, if you could speak about the vaccinations for the staff, when was it done? All of that.
Yes. So, we were lucky that in the first round of vaccines that came into Kerala, we got a substantial number. So our priority was to ensure that our frontline team was vaccinated. So we segregated them into people who are directly in contact with the patient, then people like us who are sort of there doing the background work, so that those on the floor are protected. The first round of vaccinations happened pretty quickly for the entire team, and in quick succession. If you remember that point in time, it was you had to take the second dose within a month.
4 weeks.
Yeah. So things have changed since then, but our priority was to get them all vaccinated, which is what we did. The other thing was something very small, but very interestingly, the kind of food they had. these are people who work long hours. And so we actually got together with our dietitian to create a menu which is protein-rich menu for them. The long hours of standing, long hours of being inside that PPE, very, very stressful. So actually, team came together to ensure that the kind of menu that was provided to the doctors and nurses on the floor was actually looked at by a dietitian to ensure that we gave protein-rich food. When someone got infected, what happened was that there were instances where several others were quarantined. So they may or may not have got infected, but for the next 2 weeks, they were out of action. And then, of course, came the whole, element and challenge of how do we substitute those people. So we had to reach out to locum staff. We, of course, have a pool of locum team members who come to us. So in the planning stage itself, we actually kept the pool of locum team members ready who would be able to join us at short notice. And that's what sort of in many a times that also saved the day for us, because we were looking at somewhat trained manpower. But one big challenge, and I think we did it very well, was that you can't just get another person and put them on the floor as is. They underwent sort of about a rigorous 2-week kind of a training program. We have electronic medical records, so it's a challenge to sit down and understand how it works. So we had a structured training program that helped them orient themselves to the challenges on the floor. And over time, I think we got better at it. Frankly, the issues and challenges with surge capacity in the first wave was a lot tougher to handle, because really we were, if you ask me today, we are much better prepared. But at that point in time, we were also learning, we were looking at stuff, we were making mistakes, and then trying to correct our mistakes. So the dealing with the surge capacity, suddenly your hospital, has 100+ patients, and this never happened in history. So to look at surge capacity, to look at how to cater to that surge capacity is what we did in terms of looking at alternate staff, models, local staff, training them and putting them on the floors. Mental health, I would actually want to add, this is a very stressful period for everyone. And we had a system of putting out helplines in case someone wanted to talk about stress, etc. So mental health helplines were also created so that people just reach out and perhaps talk. So these are a couple of things. I think overall, when I started this, I think our biggest challenges were how to keep your team motivated, how to keep them going despite all the challenges that we faced.
Motivation of the team was a big challenge. Mr. Golgar, you briefly mentioned vendors as well. What were the supply chain challenges you faced, and with your vendors, what were the issues?
With vendors, we have faced shortage of materials. They were not getting from the manufacturers, and the cost was going, beyond their specified rates and other things. The contracted rates were not being able to follow. And initially, first wave, we had problem of PPE kits and other safety equipment which we were supposed to be using, and there was a huge shortage of materials in the first wave. Second wave, more often, it got stabilized, but the major challenge with the vendors was with, the payments. Payment was always a problem for vendors because the cash flow was, majorly affected for hospitals, and we were also trying to manage situation with, first priority to vendors and salaries and proficiency and other kind of stuff. But we have managed. Wave 2, we did not have any problem, but wave 1 we had problems in supplies of drugs and materials. And during second wave, as you know, that remdesivir, then amphotericin, so many issues have come, and it was regulated by the government, where we have to get allocation through an ADC, and vendor, though he has the stock, he cannot deliver it to a hospital where he gets the purchase order. It has to come through a regulated authority. These were main challenges where we have faced, but we had fairly managed it well.
Okay. So at least some of those logistical issues did work out. Now, Ambili, you spoke about motivation of the staff. How about the patients? I'm sure some of your patients must have also been scared of the disease, of the entire uncertainty. Even though you are in hospital, we saw very dire situations in hospitals. For patient management, did you face any kind of challenge, or do you think with caretakers, between staff, there was not much problem?
I think in the case of patients, it was very important to demonstrate visibly that this was a safe hospital to come to. Right from how we screened, at one point in time, we experimented a lot. At one point in time, we started doing these small stickers, based on which part of the hospital you were going into, to, of course, the normal, temperature screening and all that. But we also, when we created zones, we also made sure that they were visually, you could see them clearly. One of the things about patients is that when they came into the hospital, they wanted to know whether we were following protocol ourselves. So, our own staff exhibiting safe behavior in terms of PPEs, etc., was extremely important. So, regular training, regular monitoring of behavior on the floors by staff, whether they were in PPEs or not, how our patients and their relatives were actually counseled before they came into the hospital about what are the possible risks and, what are the possible things that can happen. We wanted to make it a very, very visible affair to actually demonstrate that, look, there are things on the floor that we're doing, and it's very important that you are a part of that effort as well. India being India, many patients come in with a lot of relatives. I think everybody wants to show that whole solidarity and, that you're with the patient. And I would say that was one difficult bit, to convince patients to, ensure that you don't have a big crowd. That remains a challenge even now. But I think we were able to a large extent, convince patients and their relatives that this is not a safe thing to do. Also, one of the things is we encourage teleconsults. So we said that, look, we want you to be safe. So as far as possible, if there are review consultations, if that you need to do, why do you not switch to teleconsults? And our teleconsultation number actually went up quite a bit before, because they realized that this is a better option to do. So responsiveness, demonstration of safe behavior on the ground, giving them possible options in order to get the same result, whether it's through teleconsult or other ways, was some of the things that we did on the floor to ensure that the patients were reassured.
Okay, teleconsultation was the way to go forward. What about facilities like labs? Like, say if you have, you have cancer patients, but when you said that you are taking COVID patients and you're triaging, where do they go for testing? How do you test? Is it in-house? How long does the test take? What were the lab facilities like? Not just for COVID tests, but for the treatment of cancer patients. Did the lab undergo any change?
Definitely, in terms of, we did it two ways, right? We gave them option of home sample collections. Again, these were staff that were screened, they were in PPs, and they went to patient homes. We didn't want people to come just for the sake of sample collection if they really did not have a large agenda. So even home sample collection was an option that we gave. We made sure our staff was screened, our staff was tested. But within the hospital, what we did was that, the way my hospital, Aster Medcity, for example, is designed, you don't have one sample collection area. Each COE, we call it a Center of Excellence. So oncology has a separate area where things like sample collection take place. So you were not really mixing cancer patients with other patients. You were segregating and cohorting them in that area. So their exposure to other patients was very, very limited. I think that's a structural advantage that we have. That traditionally, if many of the hospitals will have one central area for blood collection, sample collection, and sort of cross-expose them to other patients as well. We have an advantage. Patients don't really have to get exposed to other patients because they are cohorted within the specialty that they come for. Triaging per se, like I said, if it's an inpatient, the route is different, but an outpatient, the route is completely different. You go in for the specialty that you've come for, give a sample, meet the doctor, and then you go out. So crowd management is basically what we focused on in the outpatient areas. Labs per se, like I said, apart from offering home sample collection and collection within the triage area for IP, we had the localized sample collection areas in the OPDs as well.
Right. Mr. Golgar, you also spoke about other operational challenges, about the fall in footfalls, OPD footfalls, increase in cost, and the cost pressures. Could you elaborate on that? Could you quantify the fall in footfalls? I'm guessing that the first wave, there were fewer people coming out. Was it the same in the second wave, or did they have some assurance that we'll be taken care of, the cancer patients, but the care will be such that the risk of COVID will be reduced?
Yeah. I mean, if it is precise to the cancer care, we have postponed almost all the surgeries during the wave one. I mean, COVID-19 wave one. Whereas in the second wave, it is improved. Maybe 60-70% of the surgical cases have been planned and executed. During the first wave, the occupancy was somewhere around 30 to 40%. Whereas in the wave two, occupancy went up to almost 85 to 90%. And people have accepted, it's a part and parcel of the life, though the infection is there and we need to get treated in the hospital, whether it is a surgery or a procedure or maybe another kind of investigations and other things. As our Mrs. Ambili told that, we have established home care solutions for them to get the sample collections. Then we had, different, strategies were being applied. We have ramped up our beds by putting extra beds in the hospital so that no one is refused to, refused for the care in the hospital, though there was a restriction from the government that 75% of the bed has to be reserved for them. We could able to manage fairly well in the COVID wave 2 compared to wave 1. And, of course, everybody has accepted this, right? And all offices, corporate offices, government offices, everybody has started functioning and cash was improved. So this was more or less a normal business scenario in the, wave 2.
But was there any reduction in the number of patients? Wave 1, wave 2, from the normal pre-COVID time, did you see a drop?
Normal pre-COVID time, we used to have an occupancy of 70-75%, which has reduced to 25% in the first wave.
And the second wave?
Second, we are doing around 75-80% like normal scenario.
Okay. But Mr. Golgar, you were taking care of COVID patients as well, which the government mandated you to do. So how does that work vis-a-vis being a cancer care patient, cancer care hospital? Your staff, your facilities, they're all built towards cancer care. Is there a big difference if a non-cancer COVID patient is coming through, or really for all that you spend on your facilities, what you get paid for in return is not really the same as cancer patients?
I did not understand your question properly. There was a disturbance.
No, the question is, of your hospital, which you had to reserve for the COVID patients as mandated by the government, did that put pressure on your bottom line at all? Because you said 75% occupancy you had in the second wave for the cancer patients.
Yeah. This was actually impacting on our revenue generation or the occupancy of the hospital, because 75% of the beds were reserved for government and the admissions were happening through their portal. We did not have any direct access to admit patients on our own, and we were only using 25% of the bed which were allowed for us to admit patients and treat patients. And also coming to the non-COVID and COVID patients, we could have admitted COVID patients in the allocated 25% only. And in case of excess, then they have to come to government quota. Then for non-COVID cases, then, within the 25% only we have managed. So second wave, what happened, we have added some more beds, some more COVID beds in the identified areas. So we have increased the capacity of beds compared to the normal, earlier to COVID-19 period. So that helped us, we have added almost 100 beds in the capacity. And that helped us, managing the situation of admissions and patient care.
So after you added 100 extra beds, what were the total beds, and how did you, add the extra beds given the infrastructure that you have, the existence infrastructure that you have? Was that a challenge as well,
The
Mr.
existing
Golgar?
infrastructure only, because now ours is a 6-year-old hospital where we had place for putting extra beds and for treatment of COVID patients especially. These are all government referred patients, are almost general ward patients. They are not high end special or category of patients. And we have managed, we have had conference room halls and kind of thing, and we have put beds with oxygen supply and medical requirements to be catered to the patient, and we have managed that.
That's very heartening. How quickly you came up with solutions. Ambili, were there times where you felt that this is just too much? It's just too much going around, because taking care of cancer patients on a regular day is a lot of work, because they don't they're not patients who can't be give a pill, they'll be fine and you go away. It's a long-term treatment. It's chronic care. You have to put your heart and soul in it. Plus, you have the pressure of a pandemic to take care of your existing cancer patients. Plus, the obligation to take care of regular COVID patients. At any point of time, did you feel this is too much? Did the staff feel this is too much? How did you deal with it?
Oh, being in the healthcare, we always take it as a positive, mindset, and we work hard, to achieve. And as somebody told me in the beginning of the thing, and we are in the healthcare, and we choose our career as a, social service motive also. Unlike we get our salary and family suffer because of that, but we take our hospital service as a, social obligation, and also we are motivated to do that with, many. Our senior leadership, giving us guidance, and it was an opportunity for everybody in this world to treat everybody equal, because money was not playing any major role in during that time, and whatever properties, assets, and relationship, everything went for a toss at that point of time, and we were really actually motivated to help patients. I was getting calls even at 12:30 in the midnight, and early in the morning by 3 o'clock. We were very, motivated to do all these things, and ultimately somebody told, it is a satisfaction. That's what we are working for, and we are living here, and we never take, these things as a very challenging and painful exercise to do it, but on a regular basis, it happens and happens.
Ambili, did you ever have that weak moment when you felt too much? बहुत हो गया, मुझे break चाहिए. Ambili, any moment that you felt like that?
अगर ऐसा होता तो I think this would be criminal, in the sense that you see an average nurse on the floor. I cannot tell you, the levels of motivations are superhuman. It's not possible to humanly work like that for 10 or 8 hours, and with these difficult circumstances. To answer your question truthfully, there were times when it got overwhelming, but I do not think that we allowed ourselves to feel that way, primarily because we were responsible for those who were directly dealing with patients. And like I said, when you went to look at them and what they were, I don't recall a single nurse or a single doctor coming and saying, I'm not doing this anymore. That never happened. I'm now thinking back, it's so weird. They were the one who were physically taxed. They were the one who were on the floors. How come nobody came and said that? You could see tired people, you could see overwhelmed people, but nobody ever verbalized it. I think they found their moments of, inspiration. They found their moments of motivation, and then they bashed on regardless. So in that scenario, I think the last thing people like me should be thinking that, bahut ho gaya. Like I said, it would be criminal to say or think like that. But yes, I would say that we were truly proud that we were catering to these difficult circumstances, that we were able to make a difference. It didn't come without glitches. It did come with glitches. But I think overall, the feeling was of extreme satisfaction, of pride that we were able to do this for the community. If I feel this way, you can only imagine how a doctor or a nurse on the floor feels.
Mr. Golgar, in Delhi, even the best of hospitals had a very tough time during COVID second wave. Smaller hospitals, they don't have a very large infrastructure, patients number is smaller. They're generally lower down the pyramid, and for them to raise their voice also is not so easy. In Delhi, some of the hospitals had a very hard time. Even the best, with the best facilities, great funding, great infrastructure, they were really overwhelmed for the lack of oxygen, for the lack of drugs. Did your hospital ever face this situation, Mr. Golgar, where oxygen was less, or you weren't getting drugs in time? We've seen that black marketing with remdesivir. The mucormycosis injection is not available. Did you face any of those pressures?
In fact, no. We have managed it well because now we had, stocked all our materials, with our strategy of 6 months material stock was there all the time, though the cost was a little high and we bought it at, initially it was sold at 2,000 rupees. Now it is 350 rupees per, set. But we have managed that, 6 months stock was always there. We did not have any issue of material shortage. All this while, from last 14 months, which COVID is there, and we have managed it as a pure corporate hospital, and we never refused any admission for whatever reason that, we have not denied any care for any patient as such because of material non-availability and other stuff.
Did your hospital face any cases of mucormycosis, and did you have a problem because the drug control had started using its might on the supply of this medicine? Did you have many cases in your hospital, Mr. Golgar?
No, we did not have any what do you call
mucormycosis is the black fungus.
We have managed all statutory obligations or restrictions imposed upon by the government. And in fact, there were no overcharging reported in any media area and all. So we were very, very, intact in our billing. Our compliance to statutory requirements were 100%, and we have followed quality parameters as needed for the care. And we took it as a normal business scenario.
All right, Ambili, with so many challenges and how you overcame them during the time of this pandemic, what are your lessons? What have you learned? What would you like to change, having learned something new? You just thought of something on your feet when you faced a problem. Now you think that maybe this is a thing to keep, a permanent reset. Let's do this for the future because it works better. Any new learnings from the pandemic?
Firstly, I think the whole concept of resources on the floor and how they need to be managed. There were many models that were we experimented with, and I think adversity taught us that it's great when things are hunky dory, but when you're faced with something like this, you'll have to really think out of the box. So staffing patterns, staffing models are some of the lessons that we took away. Multitasking. In the traditional models, the kind of ratios, the kind of skill sets. Can you expand skill sets for doctors and nurses to look at more than just one area? These are some of the things and ideas that we toured around with. Even in terms of resources, I think there were a couple of lessons learned on how to manage resources. I must, with a lot of thankfulness, my central procurement team was actually one of those go-to people in those times where we wanted something and how resources we are a chain of hospitals, so how resources between hospitals were managed. And it's not necessary to have stocked everything in one area, how you take and learn from each other. One of the interesting things that came up during the COVID time was that we had these meetings where we would exchange learnings on a weekly basis. And I think very, very valuable input from those, because it was then, you didn't have to make a mistake yourself to learn from that. When someone else in your group made a mistake, those learnings were passed down and you were able to make changes on the ground. So, collective learning, collectively looking at the kind of learning from mistakes, from things that happen on the floor is something that collaborative learning really, really picked up well. And that's something that we did. Listening more keenly to the team members on the floor. You had to be on the floor, right? You had to be looking at things that affected people on the floors, your patients. So I think all of us have a much more keen ear on the ground as far as listening to our patients is concerned. There were some very peculiar things that came up, things like in a normal delivery, and I'm talking about a non-cancer patient, what do you tell patient relatives? Everybody wants to be there, and how we supported a new mother to be faced it. So, adapting and learning from patient experiences, and this is going to change the way we practice medicine. It's going to change the way we, look at patient experience specifically. And it's thrown a completely different light to how we normally deal with patient needs, traditionally. So I would say, as far as staff is concerned, that's one big angle that's taken a change. Learnings on how to manage surge. I mean, this is one pandemic. It's something that we never expected, but the learnings on how to manage infrastructure, there are big learnings that's coming from there. And of course, like what I said about patient experience, I think most hospitals in the country will look at patient experience with a completely new eye. I mean, it's...
Could you dwell a little more and explain it to us? Because if there's no pandemic, like you gave the example of the delivery, everybody wants to be there. But how are things going to change now? Could you explain this patient experience reset that could happen?
Yeah. So I think, things may not change. Delivery is a very emotional affair, right? It's high emotion. But we looked at things like how can you tailor make things for the lady? How can you ensure that people are participating? So we had video conferencing. We use video conferencing to actually help her, connect with people who are away. And why can't we use this as a part of routine? Somebody wants to be connected with a relative who's abroad or who's out of town, etc. These are things that make people more comfortable and give them joy. So why limit it to just the pandemic time? I mean, these are things that we could use even when the pandemic is out. Having people who are not in their physical vicinity being a part of the care. How we could use video conferencing with relatives to actually further care and ensure that the patient experience is better. There's more collaboration between relatives. Of course, I'm not talking about the COVID patient per se, but I'm saying the non-COVID patient during the COVID time. So, things that we had to do differently could be part of the norm in the near future.
Okay. Some things could perhaps change. Mr. Golgar, in the end, from your experience, what was your learning? Ambili has spoken about patient experience. She's spoken about collaborating with peers to, ensure supplies are good. What were your learnings and any changes that you would like to carry into the future post this pandemic?
Yeah, learning is that so digital health will definitely help everybody, patients, attenders, healthcare warriors, or maybe whatever. Digital health care has a better room going forward, because we could see a lot of video calls are increasing day by day, and people don't want to come with their relatives and friends to the hospital. Like earlier days, one patient, 3 members, they used to accompany them. That has stopped, and if there is a necessity only, they will come. Otherwise, that is not required. And we have home care services, we have home isolation packages. I mean, that kind of scenario will improve, because that is the learning from COVID, where not necessarily the patient relatives and all these people have to come to the hospital unless it is very much necessary, and there is an emotional support which is required by the patient. This is what my learning is, and digital health will have a way forward in terms of patient care.
All right. Thank you so much, Mr. Golgar and Ambili, for joining us and sharing with us your views on hospital management, caring for cancer patients during the time of the COVID, caring for COVID patients, making sure nothing runs short. We want to thank you for coming here